6-month-old female who presented to the emergency department yesterday afternoon after her mother noticed she was lethargic and not acting her normal self after being in the care of her godmother. Mother reports she seemed in a normal state of health on the morning of 5:25 before she dropped her off at her godmother's house to be babysat while mom was at work. Mother reports she returned to pick up the patient around 1 p.m. in the afternoon on 5:25 and found the patient to be lethargic and she seemed dazed and wasn't tracking well. Mother reports she asked the godmother what happened, and the godmother said she fell off the couch earlier in the day, but she seemed fine. Denies any other known injury or trauma during the time that she was in her care. Due to increasing lethargy, mother called EMS and was taken to the emergency department. Patient was found to be sleeping and not tracking well and started vomiting while in the emergency department. Denies history of any bleeding concerns, denies any recent fevers, denies any recent cough, congestion, denies concerns for possibly ingesting any medications, and mother also denies any other recent diarrhea or vomiting, and had been having normal wet diapers before all this happened. Past medical history, patient is full term vaginal delivery without any complications, is able to go home with parents after birth. Patient lives at home with her married mother and father, no siblings in the home. Father is currently offshore for work, and patient has only been in the care of her mother and godmother over the past 6 months. Denies smoking in the home, denies any pets. Patient's vaccines are up to date, denies any known ill contacts. Mother denies any family history of any bleeding disorders or any other significant medical history. The patient does not attend daycare. Upon presentation to the emergency department, as we stated, patient was sleepy and difficult to arouse, not tracking well, and had 2 episodes of emesis. Based on these symptoms and clinical findings, labs were obtained as well as a head CT. Coags were obtained and normal. A urine drug screen was obtained and was negative. BNP was all within normal limits. However, the glucose was 320. She was hyperglycemic. CBC was within normal limits. Liver enzymes were elevated. AST was 1,182. ALT was 846, and lipase was 201. The head CT was performed and showed a thin, predominant hyperdense subdural collection of the left cerebral hemisphere, likely representing subacute in age, and it also showed a thin, predominant subdural collection overlying the right cerebral hemisphere. There was no mass or other hematomas. Due to concerns for non-accidental trauma, patient was admitted to the PCU for further evaluation. Before this, mother denies any prior hospitalizations, denies any prior surgeries. So upon exam, patient is 7.64 kilos. Her vital signs: heart rate 124, respiratory rate 34, temperature 37.2, blood pressure 97/46, and she's 100% on room air. So upon assessment, patient is sleeping in her crib. She's slightly difficult to awaken. However, after turning the lights on, patient startles and does wake up and reaches for mother appropriately. She's age appropriate interaction during the exam. She's in no acute distress. Her fontanelle is soft, normal cephalic head. TMs are normal, no tympanum. Nose clear, no rhinorrhea or bleeding present. She does have moist mucous membranes, no erythema or exudate. There is noted petechiae to the upper and lower lips bilaterally, and her frenulum is also has a small laceration. Her eyes are without erythema or discharge. Pupils are round, equal, and slightly sluggish, but 2+ to light. And she is tracking appropriately. Normal range of motion of her neck. Cardiovascular, normal rate and rhythm, good pulses, and good refill. Lungs are clear bilaterally, and patient is on room air. Her abdomen is soft, non-distended. She does not appear to be guarding or does not seem to be in any distress with palpation. There is no bruising or trauma noted over the abdomen. Musculoskeletal, she is moving all extremities, full range of motion. There's no swelling or deformity. Neuro-wise, patient is alert, appropriately is reaching for mother, and is able to be consoled. Her deep tendon reflexes are intact, and she does have symmetrical facial movement. Her skin is warm and dry, no rashes noted, no bruising or abrasions to the baby, and the IV is in place in the right anicule. So problem list for this patient: bilateral subdural hematomas, retinal hemorrhages, elevated liver enzymes, head injury, vomiting, a fall, concussion, ineffective health maintenance, risk for bleeding, altered mental status, pain, and risk for interrupted family processes. Differential diagnosis for this baby is a non-accidental trauma, such as child abuse, an accidental fall off the couch, possible ingestion, abdominal trauma, such as liver, spleen, or bowel laceration, a concussion, diabetes, due to her hyperglycemia upon a presentation and vomiting, hematological disorders such as factor deficiency, von Willebrand's or hemophilia or platelet disorders, vascular malformations, or gastroenteritis. So impression of the patient is 6-month-old with lethargy and vomiting after apparent fall from couch. CT findings are consistent with bilateral subdural head bleeds. Elevated glucose upon presentation to ED will be to rule out DI. Elevated liver enzymes with no acute abdominal findings. Due to concerns for possible accidental versus non-accidental trauma, patient will have a complete workup to rule out bleeding disorders. And patient is stable at this time, however, we'll continue to monitor for increased intracranial pressure in the PCU. So assessment and plan. Patient is stable, however, should remain in the PCU for neuroassessments Q2. Continue to monitor her for signs and symptoms for increased ICPs or diffuse CNS injury. We'll make sure the patient still remains appropriate for age, tolerating feeds, and it will be able to be active without difficulty to arouse. Plan is to consult ophthalmology to obtain a retinal exam, consult hematology to rule out bleeding disorders, obtain a skeletal survey as part of the non-accidental trauma workup and to rule out any other fractures, repeat the liver enzymes and continue to monitor to make sure they are trending downwards, continue neuro assessments every 2 hours, Tylenol every 4 hours for pain control, consult social work and CPS to interview the family and follow appropriately, can titrate IV fluids and advanced diet as tolerated, monitor for signs of anemia. So the findings for this patient after ophthalmology was consulted, they did find bilateral pre- and intraretinal hemorrhages in all 4 quadrants. They even stated too many to count, mostly parapapillary, but with attention all the way to the ora serrata. No macular schisis is present. It does suggest the presence of serrata hemorrhages, which is considered pathognomic finding for the shaking of the A cell, D cell shaking injury. Heme suggested labs for platelets, factor 11, factor 8, factor 9, and coags, which were all within normal range, no abnormal findings. Workup for the bleeding disorder is negative. Heme provider suggested that due to lack of personal or family history of bleeding disorder and normal bleeding studies, a bleeding disorder would be very unlikely. Skeletal survey was negative, no fractures were noted on x-rays. Abdominal ultrasound and KUB were normal, and abdominal CT was also normal without any acute findings. Repeat liver enzymes were improving. AST 45, ALT 208, and lipase 20. An MRI was obtained and stable. Findings were consistent with the previous CT scan results, so no increased bleeding on MRI. The plan will be to continue to monitor the patient medically, and when stable with discharge, patient pending discharge recommendations from CPS.